afternoon. I'm Gladys Ibanez, and I'm going to talk about a work still in progress. Why and how do we need to register the social status in the medical record? First, why do we need to do that? Health inequalities concept was first expressed at the international level in the Declaration of Alma-Ata in 1978, which stated that the existing gross inequality in the health status of the people is politically, socially, and economically unacceptable. In many countries, inequalities in health are recognized to be a major problem. Poor socio-economic status affects social, psychological, and physical health. And in primary care, the influence of the socio-economic determinants of health is important. So there are two questions. Should we adapt the traditional medical model? And should we record systematically social indicators in medical records? In practice, older people are often asked if they live alone and about their social contacts. Young single mothers also are asked about social isolation. All GPs perceive increased health problems of the poorest people, but it is difficult to account for the existence of a social gradient in health across the patient list, and that is a problem. Probably that in primary care, to be able to assess the social position of a patient could be useful for three levels of implication. At the patient level, then on a larger scale at the practice level, it means the patient list area, for example, and on a larger scale on the population level. At the patient level, social indicator would be useful, would help to reflect the social environment of an individual. For example, to assess individual risk, such as professional risk. We also know that, for example, in cardiovascular disease, social indicator, social position is very important, perhaps as important as smoking status. So it could be useful for assessing individual risk. A social indicator will also help to target people for preventive health care, such as cervical cancer screening. And it would help to target people for specific intervention, like smoking cessation programs for low-income people. At a practice level, social indicators would be useful to describe the characteristics of the patient list. For example, for continuous quality improvement, one can imagine that in a medical center, GPs could compare the blood pressure of their patients according to their social position. And it could help also to advocate for more resources for the in more deprived area for the health insurance. And finally, at the population level, the research level, social indicators in primary care are very important in public health and for monitoring health and diseases. Probably that at each step of the process of care of a general practitioner, to take into account a social indicator could be useful to tackle health inequalities. When access to the primary health care, the evaluation of patients' risk, the management of chronic conditions, and prevention to help patients' empowerment and to help for better access to prescription and referrals. So now, how do we need to register the social status in the medical record? So the objectives of our working group was to decide what to ask and what to record systematically in medical records, and then to propose recommendations. So we used the Delphi method to achieve consensus. First of all, 33 items were identified in a literature review. The panel represented a variety of professionals, clinicians, researchers, scientific society, and one union. Participants rate the importance of each social indicator using a 10-point Likert scale, and then the appropriateness of each item was coded on 1, not at all appropriate, or 10, very appropriate. Each participant can comment on each item, of course. Then this process was repeated 3 times via the internet, and then all participants compare their ratings and comment. And after completing the 3 Delphi rounds, we draft the guidelines using all the statements that achieve consensus. Then the draft guidelines were dispatched to the participants for final consensus and any comments. So here are presented the 33 social indicators identified. First of all, date of birth, age, gender, address, of course. Then ecological measures such as geographic area of residence, postal code, educational level, the highest diploma obtained, the employment status, job, no job, retired, the occupation, it means the occupation in full text, the type of work contract, if it is for the long term or a short term, working conditions, full time, past time, category of occupation, it means a socio-professional category, income, if the patient live alone, yes or not, the couple situation, marital status, the number of children and the number of dependent children or other dependents, the nationality, the geographic origin, ethnic origin, migrant status, native language, the ability to understand written language and to understand spoken language, the illiteracy, the health literacy, the social insurance status, it means no coverage, minimum coverage of social coverage and complementary insurance. Administrative situation, it means migrant status but in an administrative way. Properties owner, the standard of residence, if it's clean, old, very old, social support, perceived financial status, and some deprivation scores like EPIS or ESPS in France. Then these indicators were prioritized as follows. Some indicators were considered to be essential, very important, and must be collected for any patient. Other indicators are useful and add complementary information, and other indicators were excluded. The essential indicators were the following: the date of birth, gender, address, the employment status, and the occupation in full text. If the patient lives alone, yes or not, the social insurance status, and the ability to understand written and spoken language. These indicators were considered to be essential for any patient. This one are the useful indicators. It contains educational level, category of occupation, highest diploma, type of work contract, couple situation, marital status, health literacy, geographic area of residence, social support, perceived financial status, geographic origin, migrant status, native language, illiteracy, administrative situation, properties owner, standard of residence, and perceived financial status. So these indicators could be useful, but it depends on the situation, the patient, the context. And finally, these indicators were excluded. Household income for ethical reasons. Deprivation scores, because a score is a sum of various indicators. So it was a little bit different. Number of children, because it was considered that it was less relevant than number of dependent children. Working conditions, nationality, and ethnic origin. So it was at the patient level. Then at the practice level, many indicators are the same than as those describing the essential, but a priority has been given to simple and categorical indicators, such as socio-professional category instead of occupation in full text, and geographic area of residence instead of each address of the patient. And finally, at the population level, all indicators may be useful and are currently used. So this work is still in progress, but probably there are simple questions relevant to the particular patient and that could be asked when patients first register and at subsequent consultations. The limit of this work is that it's a French panel, so it may be less appropriate in other countries than France. And this work may be completed, could be completed by a feasibility study. Are these intrusive questions? Would it take too much time for the GP? In conclusion, the group thinks that it's not a radical change, but to assess some social indicator could be in a simply and systematic way, could be a good manner to tackle for health inequality. Thank you.